Hi everyone, and welcome to the PsySOM Pharmacology and Psychotherapy revision lecture. Before I begin, I just wanted to preface that most of the resources used to make this were taken from last year's revision lecture and our PsySOM resources, so our Pharm glossary and our summary sheets, as well as a few of my personal favorite websites, PsychDB, which I use sort of like a psych Bible, and ETG and AMH for management and Pharm with an Australian context. These slides should be available to you as you're watching this, and I've tried to make them as transparent as possible in terms of where I've gotten what information. So in the presenter notes of every slide, I've linked the specific resources that are relevant, and my reference slides at the very end will have the link to every single resource that I've used throughout this lecture. I've also put this little icon in the corner of topics that are very OSCE examinable just to make those slides a little easier to find. Now, this is the matrix with all the topics under Pharm and psychotherapy, which I understand is a lot. So the Pharm for addiction psych and mood disorders will be covered by their respective revision lectures instead of in this one. And the last couple psychotherapy topics have been addressed in our PsySOM Pharm glossary and are pretty unimportant, so I've left them out for the sake of time. That said, in this lecture, we'll be covering these 6 topics, with the first one up being antidepressants. I'm sure we're all over the indications for antidepressants, so I'm not going to read out this list to you, but I do want to remind everyone that antidepressant monotherapy is not allowed in the setting of bipolar disorder because it can trigger mania. So if you're going to prescribe someone with bipolar disorder or suspected bipolar disorder an antidepressant, you must make sure that they are on a mood stabilizer first. In terms of other practice points, it's important to remember that drug effects only peak after 4 to 6 weeks of therapy, and seizing an antidepressant, whether to switch to another agent or to stop treatment, is tapered to prevent risk of discontinuation syndrome. There are a lot of different antidepressant and antidepressant classes, so the drug choice is based on the individual patient. And in the real world, there's no hard and fast rule on how you choose an agent. Every patient tolerates antidepressants differently, and there was a landmark trial a while ago that found that none are more effective than the other at treating depression. So some physicians might have their favorite drugs that they find work for most patients, and usually they will tailor according to their patient's main symptoms. So for example, a patient has a main complaint in their depression to be insomnia, in which case you may choose mirtazapine, which is characteristically sedating, over an SSRI, which is characteristically activating. In Monash land, SSRIs are first-line agents in most cases. But I think what's more important is that we're familiar with all the relative and absolute contraindications, as well as the indications and the classic adverse effects of each drug family. Here's a diagram from the Australian and New Zealand Psych College where you can see some of the additional benefits of some drugs. You don't have to memorize this, it's just kind of handy to know and helps contextualize my earlier point a little bit. The most important thing before starting any medications is a good history and exam, and that for psych meds, it's very important to get a good history of their current medications because there are a lot of interactions and also their risk assessment, of course. Baseline bloods and ECGs aren't always necessary, but they might be indicated for specific drugs, and I'll point that out later. SSRIs are a huge topic, and you very well may get an SSRI counseling station as an OSCE. Like I already mentioned, they're usually the first-line agent for Monash questions, so you will need to know the names of the individual agents. In terms of adverse effects, Monash likes to ask about hyponatremia, especially in the elderly, but all of the 9 S's here are good to memorize. Sexual dysfunction is relevant because you're usually prescribing to young people, and this is a very important part of their daily lives and their quality of life. And of course, suicide risk is something you always have to keep in mind because it's a bit counterintuitive, but there are only 2 psychotropics that have been known to reduce suicidality, and SSRIs are not one of them. When you're counseling a patient before beginning SSRIs, you have to warn them again that effects don't kick in until 4 to 6 weeks after they've started, and that they actually might feel worse in the first 2 weeks, but they have to keep taking the medication. SSRIs are also activating, so they should be taken in the morning, otherwise they might interrupt sleep. And it's also important to safety net for serotonin syndrome and to tell them that they can't self-cease the medication because it can cause withdrawal. And I will revisit serotonin syndrome and withdrawal after I've gone through some of the other antidepressant classes. Just a bit more on initiation syndrome. It classically peaks in the first 1 to 2-ish weeks after initiating therapy and should start improving from around the end of that period, so around 10 days to the end of the 2 weeks. Patients should be very closely monitored in this period, especially if they have a history of suicidal ideation. So ideally, you should arrange a follow-up anywhere between 2 to 6 weeks, depending on how concerned you are. Understanding that if you see them before 4 to 6 weeks are over, the drug might not be in full effect yet. And again, just wanted to reinforce, you should warn the patient that they are very likely going to feel a lot worse in the first 2 weeks, and it's completely normal. And if they're feeling particularly at risk, to contact you or to contact a helpline. You definitely need to be able to recognize fluoxetine, sertraline, and escitalopram. I've put the brand names here for completion because doctors and patients like to use them and it gets really confusing, but the brand names won't be used in your exams. It should be generic names only. And again, for the sake of exams, fluoxetine is first line in adolescence because it has the longest half-life, which means that it's more forgiving if you accidentally miss a dose, as adolescents tend to do. S for sertraline is S for safest in pregnancy and S for safest in increased cardiovascular risk. If a patient needs an SSRI and they are pregnant or they are planning to get pregnant, the answer is probably sertraline. The buzzword for escitalopram is anxiety disorders or even depression with concurrent anxiety symptoms. And the adverse effect profile is pretty good for this one. These three agents don't come up as much, but you should remember that paroxetine is a known teratogen. So it's the only SSRI that's absolutely contraindicated in pregnancy. It's also just generally a little nasty, as you can see over here, so we don't love it. And just to revisit that point just then, all SSRIs except for paroxetine are actually safe for pregnancy. So sometimes you might get a question in that OSCE station from your patient, where you just have to reassure them, yes, you can keep taking your antidepressants. In fact, we do want you to stay on your antidepressant so that your mood and your emotional state can be stabilized during your pregnancy. Onto our tricyclic antidepressants. These drugs are not first line for the treatment of major depression. In fact, they're more used for neuropathic pain now, or if the patient has failed other antidepressants, i.e. treatment-resistant depression. This is because they have so many adverse effects, basically all the SSRI side effects, plus anticholinergic, plus cardiac. And because of this, they're much more likely to be fatal in an overdose. I've never seen TCA overdose tested before, so I don't think it's that high yield. And if you're curious, I have some extra details in the presenter notes in terms of like the ECG and like the signs and stuff. You just need to know that tricyclics are not good. These drugs ideally need a baseline ECG because, again, they have a lot of cardiac side effects. So I like to remember TCA as standing for terrible cardiac adverse effects. Don't know if that's going to help anyone, but that's how I remember it. Amitriptyline and nortriptyline do come up sometimes in exams, but I think you should be okay if you can just recognize them as TCAs. I don't think you're going to get an OSCE station counseling someone on a TCA specifically. I don't think you're going to get any questions like that are really nitty-gritty details about tricyclics. And to be honest, I've only really seen amitriptyline used to treat neuropathic pain rather than for depression. Like TCAs, MAOIs are never a first-line agent because they have so many contraindications and so many side effects. Now, over here, I did specify reversible and irreversible agents, but again, it's pretty low yield. And I have some notes on the reversible versus irreversible MAOIs in the presenter notes, and they're also in our other resources. And of course, the one thing we all remember about MAOIs is that you can't have them with tyramine-rich foods like cheese because it can cause a hypertensive crisis. So it's not just cheese, it's also anything fermented, so wine, beer, stone fruit, sorry, not stone fruit, dried fruit, sourdough, because you inhibit the formulation or the abundance of your monoamine oxidases. That increases your level of tyramine. Tyramine displaces a bunch of noradrenaline. All that noradrenaline gives you a hypertensive crisis. Okay, SNRIs are a very big topic. So they are much more high yield than your TCAs and MAOIs. They're generally considered second line for depression. I think in the real world, people do just get prescribed SNRI straight away over an SSRI. I think that's beyond the scope of fourth year. But like TCAs, sometimes they are used for neuropathic pain. And if you've had your ONG rotation already, you should know that they are also used to treat the vasomotor symptoms of menopause, which I will not be elaborating on because this is a psych pharm lecture. Otherwise, their characteristics and contraindications are similar to SSRIs, with the added side effects caused by increased noradrenaline uptake. I think the most idiosyncratic one is the strange dreams and nightmares. You need to be able to recognize venlafaxine, desvenlafaxine, and duloxetine. The biggest issue with venlafaxine is the sexual dysfunction, which again, you're prescribing to a young patient where this is important to them. And this is because the serotonin and adrenaline pathways are both affected. So they kind of stack. So it's worse than SSRIs. It also has a short half-life and needs BD dosing, which means that it has a higher risk of causing withdrawal symptoms. Because you can imagine if they miss their afternoon dose, then the half-life wears off and then you slip into withdrawal. And again, duloxetine, nowadays, I think not used as much in an antidepressant context, more so used for neuropathic pain. These are some miscellaneous antidepressants that come up sometimes as options in the multiple choice section. You don't really need to know their class. I didn't know their classes until I was making this PowerPoint. The one thing you need to know most on here, I think, is probably mirtazapine, which is a tetracyclic antidepressant, not a tricyclic, tetracyclic, which is characteristically sedating, and also causes a lot of weight gain. But it's preferred in the elderly because it's less likely to cause hyponatremia. Agomelatine is handy to know. It's not super high yield, but it's kind of different from the other drugs because it needs serial LFTs when you're commencing treatment, and its effect is pretty easy to remember because it has melatonin in its name. Discontinuation syndrome is the same thing as experiencing withdrawal symptoms. It's just a fancy name for it. All of the agents that have been mentioned today can cause withdrawal, but the most likely ones are venlafaxine and paroxetine because of their short half-lives. The withdrawal symptoms usually come up 1 to 3 days after seizing the drug, and usually after they've been on that agent for at least 7 weeks. So honestly, as soon as they start sort of feeling the effects of the drug, they're at risk of experiencing discontinuation syndrome if they stop it suddenly. FINISH is the acronym for it. And usually Monash will say something about a patient experiencing symptoms like nausea, headache, lightheadedness, chills, body aches, etc. And then the most buzzwordy is the brain zaps or the lightning zaps. Most cases are mild and you don't need intervention, but in severe cases, you will restart the drug so that you can taper it off properly. Again, I think it would be really mean to have a management OSCE on how you're going to taper someone who's slipped into discontinuation syndrome. It's most likely that you're just going to have to need to be able to recognize it on an MCQ. I have a bit more detail in the presenter notes again, if you're curious. Serotonin syndrome is the antidepressant medical emergency, but a lot of things can cause it, even drugs that are not antidepressants, like opioids or recreational drugs. Usually the presentation is in the setting of an overdose, or if there's a combination of multiple agents. So for example, someone is on an SSRI and then also is prescribed opioids for pain, or then someone is on an SSRI and they then take recreational drugs. MAOIs are important to screen for here because monoamine oxidases, which are the enzymes that they're inhibiting, they break down tyramine, which is the cheese one, but they also break down other drugs. So you need extra time to wash out maois, otherwise it will impact the way the other meds are broken in the body, which could then cause the serotonergic effects of the drugs to stack, and then cause serotonin syndrome. Enzyme activity returns when the new monoamine oxidases are resynthesized, which takes around 14 days, hence why you need to make sure the patient has not had a MAOI in the past 14 days. The acronym for serotonin syndrome is SHIVERS, and usually the patient is sweaty, hyperreflexic with clonus, and hemodynamically unstable. It could be hypertension, it could be hypotension. It's treated by stopping the agent and starting diazepam. And according to ETG, cyproheptadine is second line to diazepam, but I think this is written differently in different resources. And again, I think it'd be really mean for Manish to test you on the exact order. It's just good to remember cold IV, diazepam, cyproheptadine. That wraps up antidepressants, and now we're just going to move on to mood stabilizers. Aside from lithium and atypical antipsychotics, mood stabilizers are also our anti-epileptic drugs. And just a reminder that I will only be talking about the drugs and not the management of bipolar disorder, which has been covered in our mood disorders lecture. In terms of practice points for mood stabilizers, remember that most of them are teratogenic, and the onset of effect is generally faster acting than antidepressants, but still not instant. So they're not the only agent used to manage acute mania. And again, this has been covered in the mood disorders lecture. I will mention one more time because it's very important, but most of these agents are teratogenic. So screening for pregnancy is important before starting a mood stabilizer. Otherwise, the baseline bloods are mostly related to the effects of lithium and valproate, which are our first and second line agents. Lithium counseling is a potential OSCE topic. It is the gold standard mood stabilizer, and for the sake of exams, everyone with diagnosed bipolar is on lithium prophylactically unless they have contraindications like severe renal disease. Lithium use in the first trimester of pregnancy is known to cause Epstein anomaly, which is like a cardiac thing, but pregnancy is only a relative contraindication because sometimes stabilizing mood outweighs the risks of lithium use. And the safer drugs are generally poorer mood stabilizers or at least poorer anti-manic agents. So we'd rather risk a predictable cardiac abnormality in the fetus versus a pregnant person slipping into mania and engaging in high-risk behavior. The acronym for the adverse effects is lithium R, where unfortunately the M does stand for miscellaneous. I usually just remember as M for metallic taste because it's probably the most buzzwordy one. And then the other important ones are renal failure and thyroid dysfunction. And diabetes insipidus is important because lithium is entirely excreted through the kidneys. So the concentration in blood is very dependent on fluid levels, which means it causes a bit of a vicious cycle because you get insipidus from lithium, then you're peeing a lot, and then concentrating that lithium again. Lithium has a narrow therapeutic index, which means that the dose at which it is clinically effective is only slightly lower than the dose at which it becomes toxic. The values in this table have been taken from ETG, but I've seen past student resources say 2.0 is a severe concentration. I think it's just more important to know to aim for 0.6 to 0.8 plasma lithium levels. So if their levels are over 1.8 or like over 1 and they're unwell, we treat the patient rather than the number. When you're counseling someone, I think this applies to all psych drugs, but lithium especially, you really have to stress the importance of compliance. So you can say something like, it's very important that you do not miss taking this medication every day because otherwise it will not only be less effective, but it could also be dangerous. Take it with food and make sure that you are drinking lots of water, especially when it's warm. And when you're on this medication, you will need regular blood tests because we need to check how much of it is in your bloodstream and make sure that it's not having an effect on organs like your thyroid and your kidneys. If you ever want to stop taking this medication, please let us know because we have to do it slowly to prevent side effects. Make sure you also safety net for toxicity. So you can say, if you find yourself being constantly thirsty despite drinking lots of water or frequently needing to urinate, please let us know. And sometimes people feel nauseous when they're taking lithium, but it should improve over some time. And if it's making you vomit, you also need to let us know. The second line mood stabilizer is valproate, but this one is very teratogenic, so it is absolutely contraindicated in any patient who can get pregnant. And it also potentially decreases the effectiveness of oral contraception. So if your patient can get pregnant and they have to be on valproate because lithium doesn't work for some reason or any other reason, it's safer to have them on long-acting agents like the Implanon or Mirena. However, valproate is safer than lithium in breastfeeding because lithium passes through the barrier, but valproate does not. The acronym is valproates. The most important ones or the characteristic ones are probably weight gain, sedating, and liver toxicity. So deranged LFTs. It can cause hepatic failure, but very rarely. These are some of the other mood stabilizers. They're all R2 drugs. The main thing to know about carbamazepine is that it can cause agranulocytosis and it's teratogenic. The main thing to know about lamotrigine is that it is probably the safest one in pregnancy. It's still not great because it can cause cleft lip, but it's not very good at treating mania, so it's usually not the mood stabilizer of choice. The atypical antipsychotics can also be used, and they're safer in pregnancy, but I think it's beyond the scope of fourth year to know when to apply them in the context of bipolar disorder, as long as you know that they can function as mood stabilizers. And I'll talk about their safety profiles in the next section, which leads us to antipsychotics. So antipsychotics have a pretty wide range of applications outside of psychosis. Like I just mentioned, it's used in acute mania and as mood stabilizers in bipolar disorder, and can also be used to treat the behavioral and psychological symptoms of dementia, and among other things. The older drugs are now often used for migraines or nausea rather than for treating psychotic disorders. And a lot of them are sedating, so it's good when you're counseling to mention avoiding driving and operating heavy machinery, etc., until they've been on the drug for a while so they know how the medication is affecting them. Like with most psych drugs, non-adherence has bad outcomes, so you always need to stress the importance of taking medication. Before we delve into our typical and atypical antipsychotics, I think it's pretty helpful to have a brief overview of the dopamine hypothesis, which describes the four main dopamine pathways in the brain, aka the mesocortical, mesolimbic, nigrostriatal, and tuberoinfundibular pathways. The main hypothesis for the pathophysiology of schizophrenia or psychosis is an imbalance in these pathways, mainly mesocortical and mesolimbic. For example, when your mesolimbic pathway is overactive, you get extra feelings of reward or desire, and this is why we think you can get substance-induced psychosis, addiction, and we hypothesize our positive symptoms of schizophrenia. On the other hand, in schizophrenia, we tend to see an underactive mesocortical pathway, which manifests in our negative and cognitive symptoms. So when antipsychotics were first being created, the positive symptoms were more disruptive and thus had a higher priority to be addressed than the negative symptoms. So our first generation drugs and kind of the second generation drugs as well are essentially dopamine antagonists. However, because there is crossover in the dopamine pathways, as in you can't just block the mesolimbic pathway, you see adverse effects, mainly the movement disorders and hyperprolactinemia. This is also why those with chronic schizophrenia tend to have very flat affects, because the prolonged antipsychotic use further suppresses the mesocortical pathway. Metabolic profile is the thing to think about for antipsychotics because basically all of the atypicals increase appetite and diabetes risk. The EEG is probably not necessary. It's just put there because we know that clozapine is a seizure risk. And again, reminder that this is not the baseline workup for the management of psychosis. This is the baseline workup that is needed before starting someone on antipsychotics. So our psychotic disorders lecture will have a much better overview on the whole baseline workup for psychosis. A very general separation of our typicals or first-gen drugs versus our atypicals or second-gen drugs is that our typical agents are potent D2 antagonists and very commonly cause extrapyramidal side effects. Atypicals are less likely to cause EPSCs, but definitely still can, especially when used at higher doses. However, their most concerning adverse effect is their cardiometabolic side effects. You do need to know these drugs. Haloperidol and chlorpromazine probably come up the most, but zeuclopenthixol is often one of the options in the MCQs, usually not the answer. I've arranged the drugs in order of their potency at the D2 receptor, which means that of the first-gen agents, haloperidol is the most likely to cause EPSEs. Chlorpromazine is still classed as an antipsychotic, but it has a really bad side effect profile, as you can see here. So we only really use it to treat migraines now. You don't need to know that it's diluted in 1 liter of sodium chloride. That's just there for completion. Now, our second-gen agents, olanzapine is used a lot in acute situations because it's quite good at controlling psychosis. However, it has the worst cardiometabolic profile aside from clozapine, and it's very sedative, so we don't like to use it for prophylaxis or long-term use. Quetiapine, for some reason, in Monash land is often used to treat psychosis in Parkinson's. And a fun fact about quetiapine is that it's sedating in lower doses and only more strongly antipsychotic at higher doses. So for some patients, it's prescribed in low doses to help with sleep. That was just a fun fact. I don't think Monash is going to ask you that on an exam. Risperidone and paliperidone are very buzzwordy for hyperprolactinemia. And aripiprazole has a pretty different mode of action, which makes it have the best metabolic profile. It's actually sometimes called a third-generation antipsychotic. However, it is the most likely to cause akathisias, which is a type of EPSE. So a likely OSCE station for antipsychotics is clozapine counseling. And some fun history about clozapine, it was actually the first second-generation antipsychotic created. And essentially, they took a tricyclic antidepressant, remember that they have lots of cardiac side effects, and they tweaked it a bit to be more sedating because they're trying to treat positive symptoms. Now, it turned out to be really good at controlling psychosis, but then it also started inducing agranulocytosis and it killed a bunch of the trial patients, caused a bunch of other problems too. So they took the structure and they adjusted it a little again, and that's how they got olanzapine. So you can kind of think of the side effects as olanzapine turned up to 200%. Lots of weight gain, lots of sedation, lots of anticholinergic side effects. So that's why paralytic ileus is a contraindication. It's most classically, it's known for agranulocytosis, so myeloproliferative disorders are contraindicated, and myocarditis, and it can also cause seizures, so that's why uncontrolled epilepsy is contraindicated. When a patient starts clozapine, they need a baseline ECG and bloods to check their neutrophil count, their sugars, and their CRP and CHOPS. And they also need to have the temperature taken for the first 28 days to check for febrile neutropenia. Now, in terms of indications, because clozapine is very effective but very dangerous, it is only indicated when someone has failed 2 other agents for schizophrenia. Experiencing EPSEs is an indication there because it is the least likely antipsychotic to cause EPSEs. If you're curious why, I've put the explanation in the presenter notes, but it's not that important. Clozapine and lithium are also the only 2 psychotropics that have been proven to reduce suicidality. So every other psychotropic doesn't have that much evidence, but these 2 do. For clozapine as well, you have to get a smoking history because smoking can change the levels by up to 50%. So if they are smoking, it will lower the levels. So this means if they are a smoker when they start therapy and then in the middle they decide they want to quit, their clozapine levels will drastically rise, and then you have to be worried about toxicity. And then the opposite is true. If they're continually smoking or they pick up smoking while they're on clozapine, then the levels are going to need adjusting to. Okay, on to our adverse effects. The first one is our extrapyramidal side effects, and then the acronym to help you remember them is ADAPT. A mnemonic for the timeline of the symptoms you can use is acute dystonia occurs within 4 days, Parkinsonism occurs within 4 weeks, Akathisia occurs within 4 months, and tardive dyskinesia occurs in chronic use. For acute dystonia and Parkinsonism, the treatment is benztropine, which is an anticholinergic drug. And akathisia is more related to sort of GABA and serotonin, so that is treated with diazepam and propranolol. Importantly, you do not use benztropine in tardive dyskinesia because it can actually make it worse. So the names really confuse me, so I've put a few slides here just to have examples of each EPSE. Dystonia, you think dystonia, so plus tone. They sort of have this abnormal posture, which is quite rigid, and they have this classic eye sign where they're always looking up and out. There's akathisia, where it's just this motor restlessness. So if they're sitting down, they might be moving their feet like this or just moving their whole body. Parkinsonism, we all know. And tardive dyskinesia is the chronic one. So it's not going to be something that pops up when someone's just been started on an antipsychotic. The most characteristic one is the mouth puckering. So here's a little timeline, visual timeline, courtesy of PsychDB. Remember that acute dystonia and akathesias are more short-term and tardive dyskinesia is chronic. Acute dystonia is more likely to be an emergency than akathisia. Akathisia is just sort of that restlessness. And it's meant to go away or improve as therapy continues. I've touched on the cardiometabolic adverse effects already, so I'm not going to spend too much time on this slide. Just remember that schizophrenia itself is a cardiovascular risk factor, so adding on atypical antipsychotics makes it very important to monitor your patient's metabolic profile. Neuroleptic malignant syndrome is the medical emergency of antipsychotics. The acronym is FEVR, and the characteristic thing to look out for is rigidity with a CK rise because of the rhabdomyolysis. Now, unlike EPSEs, this is treated with a dopamine agonist called bromocriptine. Monash loves to test neuroleptic malignant syndrome versus serotonin syndrome, and they can appear very similar, so I've made a table comparing them. Both of them present with fevers and hemodynamic instability and a very fast onset. However, serotonin syndrome has hyperreflexia and clonus, and neuroleptic malignant syndrome has rigidity and CK rise. And obviously, they both have different treatments. So we've gotten over the 3 bulky topics, and the last few sections are going to be a lot briefer. For sedatives and hypnotics, the main drugs we need to know are benzos. The R2s, which I do have a slide on later, really rarely come up. Benzos are great drugs for acute agitation and insomnia. However, they have a very big dependence issue. And you can see that my indications list is obviously not exhaustive because they have so many indications I couldn't fit them on the page. Acute alcohol withdrawal, status epilepticus, acute mania, sedation, etc. But it's always used in a short-term context because of the dependence issue. They also have a lot of adverse effects, which you can use the ABCDEF acronym for. And remember that there is a risk of respiratory depression that is greatly increased when taken together with alcohol, which is why it can only be used for alcohol withdrawal in a context where the patient is no longer drinking alcohol, as in they are in the hospital. Benzos in the elderly are also very important to remember. Not only are they a huge falls risk, they are also metabolized in the liver, which are usually not good in elderly people, and they're also more likely to cause paradoxical reactions in elderly people, which basically just means that it actually makes their anxiety and agitation worse instead of better. Benzo names are pretty easy to remember because they always end in lam or pam. And you don't really need to know the half-lives in too much detail, but it's handy to know that diazepam is longer acting and midazolam and temazepam are shorter acting because it changes what they're specifically indicated for. So diazepam is the drug of choice in alcohol withdrawal because it lasts a while, but temazepam is the drug of choice in insomnia because you take it right before you go to sleep, helps you fall asleep, and then hopefully when you wake up the next morning, you're not drowsy. It's also good to remember the lot drugs, so Loraz, Oxaz, Tamaz, which are better in the setting of impaired liver function because they're metabolized differently. So we prefer these in the elderly and, of course, those with liver impairment. Very, very brief overview of the two R2 drugs. They're very similar in both name and indication. Just remember that sopraclone is bitter and zolpidem causes parasomnias. Psychostimulants. These are very well known, of course, to treat ADHD, but they're also the main treatment for other conditions like narcolepsy and binge eating disorder. They're known to stunt growth, so we prefer not to use them in young children, especially those under 6 years old. And remember that these are controlled drugs as well, so it's important to screen for a history of substance misuse. Dexamphetamine is the only amphetamine drug on the psych matrix, but I've put lisdexamphetamine, more commonly known as Vyvanse, on the slide for completion. I don't know why it's not on the matrix. It's literally just the long-acting formulation of it. The contraindications and side effects are pretty intuitive for amphetamines, mostly that they cause anorexia and then weight loss. Obviously, they cause blood pressure issues and cardiovascular concerns and like the GI things. And very rarely they can cause liver dysfunction. But otherwise, I think it's pretty intuitive. So if you think about the contraindications, pheochromocytoma, hypothyroidism, hypertension, you're just worried about your blood pressure mostly, glaucoma because of the eye pressure, cardiovascular health, and the MAOI because, again, tyramine hypertensive crises. The two non-amphetamine drugs on the matrix are here, and for all intents and purposes, the characteristics and adverse effects for methylphenidate is pretty much the same as amphetamines, and they're used to treat the same things. Modafinil is a little different because it is actually not used to treat ADHD. It's more specific to narcolepsy and other sleep issues like daytime sleepiness caused by OSA and shift work. Last section, and to quote the Moodle module directly, all psychotherapies are R3 on the curriculum, and therefore you only need to know their definitions and indications. So, CBT, aka cognitive behavioral therapy, is the gold standard in anxiety, depression, and OCD. It's definitely the one that comes up the most in the MCQs because it's been proven to be as effective as pharmacological therapy in mild to moderate depression. And ideally, we want our patients to be on a combination of both. It's considered a short-term to medium-term therapy, which is made of a bunch of workshops and worksheets and stuff. It focuses on addressing negative thought processes. Psychodynamic psychotherapy has slightly broader applications than CBT, but the most characteristic thing about it is that it's for patients who are not in an active crisis, who are more stable. So not actively suicidal, not actively misusing substances, that sort of stuff. Supportive psychotherapy is something that anyone can do and is for cases that don't really require that extra support. Family therapy is an umbrella term. The only thing you really need to know about it is that it's buzzwordy for anything to do with eating disorders in adolescence. Motivational interviewing, we all know. DBT, dialectical behavioral therapy, is very buzzwordy for borderline personality disorder. Its main focus is on improving emotional regulation, which is the biggest issue in borderline personality disorder, and it's made up of individual classes and group therapy. Okay, we've made it to the very end of the lecture. So if you don't want to go through any past exam questions with me, you can exit now. Otherwise, I'm just going to go through, I think, 6 past exam questions just to help contextualize what we've learned today. You can pause right here. Otherwise, I'm going to move on to the answer in 3, 2, 1. So the answer to this question is mirtazapine. And this is because we are looking for an antidepressant that is not an SSRI or an SNRI. And that narrows it down to mirtazapine, amitriptyline, or reboxetine. His chronic insomnia, and chronic means you can't give him a benzo to help treat the insomnia, that is indicative for mirtazapine, and his age also points us sort of in that direction. But more importantly, amitriptyline and reboxetine are both not great options because he has cardiovascular complications. Next question. Pause so you can read and have a think about it, and I'll move on to the answer in 3, 2, 1. So clozapine plus flu-like symptoms immediately implies agranulocytosis. This means that the most appropriate thing to check first would be the patient's blood count. Now, obviously in real life, they would be doing most of these things concurrently, but for the sake of exams, we're choosing the most appropriate investigation and assuming that nothing has been checked yet. Now, I did want to flag this wording here because it's not always the same in the exam question. Sometimes they ask what the first thing you would do is, or like the first investigation you would choose, in which case you'd choose something that's faster because it's usually like an emergency situation, or something that's less expensive or like less intensive. Or they might ask like what's the next most appropriate investigation if they've done something already. So just make sure you read this part of the STEM carefully because it's not always the same. All right, moving on to the next question. Pause here. And I'll move on in 3, 2, 1. Okay, I know I literally said in this lecture that I've never seen a TCA overdose specifically tested before, and I still stand by that because this question isn't asking you how to treat one or to recognize the symptoms of it. However, the anticholinergic side effects that the patient was complaining about, along with the treatment-resistant depression and the medication being an older class, indicates that she was very likely treating her depression with the tricyclic antidepressant. Now, remember what TCA stands for. Not tricyclic antidepressant, terrible cardiac adverse effects. Therefore, we need to get her an ECG first and foremost. All right, next question. Pause here and moving on in 3, 2, 1. So James is experiencing depression that is severe enough to significantly impact his daily functioning. So a self-help group or psychotherapy alone won't be adequate enough to manage it at this point. He's not in a crisis, so he doesn't need admission to a hospital. But in my opinion, we'd ideally want him on a combination of CBT and pharmacotherapy right now. But because of the severity of his symptoms, it would be appropriate to try starting him on an antidepressant. And remember that out of the drugs we have here that are antidepressants, escitalopram, fluoxetine, mirtazapine, that adolescents are a buzzword for fluoxetine. So that's why that's our answer. Escitalopram, he doesn't really have any anxiety symptoms that have been brought out in the STEM, so there's not specifically an indication for that one. And mirtazapine's not like the same thing. There's not really any specific indications for it. More importantly, there's nothing that's overtly contraindicating fluoxetine or an ssri. So that's just our default choice. All right, next question. And I'm moving on in 3, 2, 1. So like in the last question, Sandra is unfortunately quite depressed. And again, hospitalization is not indicated because she's not actively suicidal. However, she does need some pharmacological intervention. Because of her low libido, her insomnia, and her weight loss, an SSRI is not the best option here. However, mirtazapine happens to address all of these issues, so this is the drug of choice in this scenario. Next question. Pause here. And moving on in 3, 2, 1. Grace has only tried one SSRI, and I think they tried really hard to point out that she's specifically only tried one. And the general rule is that you can try 2 drugs of the same class before you abandon it and move on to something else. So she's still amenable to trying another SSRI. Plus, she also has the symptoms of anxiety, which again is buzzwordy for escitalopram, so that's how we ended up here. Venlafaxine is the only other thing you could really consider out of this list of options, except for maybe CBT, but again, they said they tried psychotherapy already. And the only thing you could really stretch to think about prioritizing venlafaxine over escitalopram is like her age group, kind of putting her in that perimenopausal period, but she hasn't been complaining about any vasomotor symptoms or anything like that, or pain. So we'd stick to escitalopram. And I think this is our last question. So pause here, and I'll move on in 3, 2, 1. The answer to this question is supportive therapy. And the reason for that is because there's no real indication in the stem that this is having a significant effect on her activities of daily living or her ability to function generally. So because of that, at this point in time, there's no need to jump straight to medication or even more intensive or more specialized psychotherapy unless we give those a shot and things don't improve or they escalate really quickly. That brings us to the end of our revision lecture. Thank you for making it all the way to the end. If you've got any questions, you can email me here, or you can find us on Facebook, Instagram. I think our website is currently down, but you'll be able to find all our resources on our Google Drive. And yeah, thanks for coming.